Okay, so today we're diving into something you might have heard of, diabetes. But we're really zeroing in on a very specific thing called hyperosmolar hyperglycemic syndrome, HHS. You've probably heard of diabetes, but this is going deep.
Yeah, that's right. And I mean, we all kind of have a sense that diabetes means high blood sugar. But HHS is a very, very particular and serious situation that can develop, and it's mostly in folks with type 2 diabetes. It's basically this really, it's extremely high blood sugar and really significant dehydration, like really dehydrated.
Yeah, and it's not something to take lightly. I mean, what really jumped out at me when we were researching this was, you look at the numbers and the mortality rate for HHS can be, potentially 10 times higher, 10
Right.
times higher than what you see with DKA.
Absolutely. And while DKA is more common in type 1, HHS is overwhelmingly associated with type 2.
And just to really drive that point home, I mean, that's not just a statistic. Like that really underscores that, any of the warning signs that we're going to be talking about today, you have to take seriously, like super seriously.
Yeah, you got act fast.
Act fast. Exactly.
And it's kind of interesting, too. This isn't some, brand new thing. There are descriptions that sound a lot like HHS that go all the way back to like the 1880s.
Wow.
So, doctors have known about this for quite a while.
Yeah. So today, for you listening, the goal is to really get a grasp on these critical details of HHS. Like what exactly is going on in the body? Who's really at risk for this? What are the things that actually trigger it? How do doctors even identify it? And probably most importantly, how is this thing managed? What do you do? So to kind of set the stage, maybe we should rewind a little bit and talk about just the basics of diabetes.
Sure, yeah. So at the core of it, diabetes mellitus is all about hyperglycemia. That's just a fancy way of saying high blood sugar. And that happens because of a problem with insulin. And insulin is a hormone, a really crucial hormone. It's made in the beta cells of your pancreas. And basically, insulin's job is to help glucose, which is, your body's main energy source, to move from your blood into your cells where it can actually be used or stored. And it also has this other job of preventing the breakdown of fats.
Okay, and there are different types of diabetes, right? I mean, we hear about type 1, type 2.
Right, exactly. So type 1 diabetes, it's an autoimmune condition. That means your body's own immune system is basically attacking and destroying those beta cells that make insulin. And that leads to, a really severe lack of insulin. And the more common kind of acute complication that we see is DKA. But then there's type 2 diabetes, which is much more common. I mean, like 90 to 95% of all diabetes is type 2. And in type 2, your body's cells, they become resistant to the effects of insulin. So your pancreas might still be making some insulin, at least, early on, but it's not enough to overcome that resistance. And that's really the scenario where HHS is most likely to develop.
Okay. So with that as our foundation, let's kind of dig in here. Why does HHS even happen? What are the things that kind of push someone, who has type 2 into this really dangerous state? What are the triggers?
Okay, well, the key here, it's usually this combo of type 2 diabetes that's not well controlled, and then some sort of triggering factor that throws things way off balance. Like infections, those are a huge cause. It's like 50 to 60% of HHS cases. I mean, those are the big ones. And these can be like respiratory infections, problems in your GI tract, or even UTIs.
Right.
So when you're fighting off an infection, your body can lose a lot of water through what we call insensible water loss. And it also pumps out these stress hormones like catecholamines, think adrenaline, things like that. And that drives your blood sugar way up.
Right, because your body's stressed. So it's like, we need some fuel. We need energy. So it's releasing glucose.
Right.
Makes sense. Now, are there other triggers that you think are, important for people to know about, like specific things?
Yeah, definitely. Some medications, especially for older adults with type 2 diabetes, can increase the risk. So things like thiazide diuretics, beta blockers, glucocorticoids, those are steroids, and even some of the atypical antipsychotics, those have been linked to HHS, and also cardiovascular events, like if someone has a stroke or angina or even a heart attack. All of those things can trigger a huge stress response in the body. So again, it's like the surge of those counter-regulatory hormones, and your glucose just shoots up.
Now, that's interesting. Our sources also highlighted obesity and consuming lots of sugary drinks.
Oh, yeah.
As a contributing factor, particularly in the context of this increase in HHS cases that they're seeing in kids and younger adults.
Yeah, that's a big one. It really highlights how how big of a role it plays.
Yeah, it's huge.
So yeah, with childhood obesity on the rise, And you see type 2 diabetes happening younger and younger. Unfortunately, we're seeing more HHS in these age groups too.
Right. So that kind of paints the picture of why it might happen. But who's most at risk? Like, are there certain groups we should be like extra aware of?
Well, traditionally, HHS has been more common in older adults. So, people in their 50s and 60s, that sort of age group. And that's actually in contrast to DKA, which, we were saying earlier, is more common in younger folks, maybe in their 40s. But like we were just talking about, that rise in pediatric HHS because of the childhood obesity problem, that's something we really got to be aware of.
And are there any racial or ethnic groups that seem to be more affected?
Yeah. Our sources pointed to a higher incidence of HHS in African Americans, Native Americans, and Hispanics.
Okay.
And that's probably linked to the higher prevalence of type 2 diabetes in those communities. And there was also a specific mention of a really severe risk for morbidly obese African American males.
Wow.
So it's like all these risk factors can really, stack up.
They compound on each other. Yeah, that gives us a much clearer picture of who we're talking about.
Yeah.
But let's dive even deeper into, the why of it all. Like what's actually happening in the body, the mechanisms that lead to HHS.
Okay, well, the main issue, like with diabetes in general, it's a lack of effective insulin.
Right.
So even though there might be some insulin in type 2 diabetes, it's not enough to really bring that blood glucose down.
Okay.
And so you get this significant hyperglycemia. I mean, you're talking glucose levels over 600 milligrams per deciliter.
Oh.
And at that level, your body cells, they're essentially starved of energy.
Right.
And this is what triggers the release of those counterregulatory hormones we talked about before, like glucagon, growth hormone, cortisol, catecholamines, all of that. And then those hormones, they make things worse.
Oh, no.
They tell your liver to produce even more glucose.
Oh, my gosh.
So it's like this vicious cycle.
It's a really, really bad feedback loop.
Yeah.
Okay,
What?
so it's this high glucose,
Yeah.
and then the body trying to fix it, but actually making it worse. Exactly.
And that's what leads to the hyperosmolar part, right?
Right. So that super high glucose, it dramatically increases what we call serum osmolality, which is basically the concentration of dissolved particles in your blood. So normally it's like, around 280, 290 millimolaise per kilogram. But in HHS, it often goes above 320. And we've seen it as high as 400.
Oh.
So imagine, your blood is like a glass of water with sugar dissolved in it. In HHS, there's just a ton of sugar in there, right? So it's very concentrated. And that pulls water out of your cells, even your brain cells, into the bloodstream. And then, because your blood has all this extra glucose, your kidneys try to flush it out in your urine.
Right.
And they take water and electrolytes with it.
Okay.
And this is called osmotic diuresis. It leads to severe, severe dehydration, often worse than what you see in DKA. And that's a big reason why, that risk of cardiovascular collapse, that's why HHS is so dangerous.
Right. So it all comes back to the dehydration. It's not just the blood sugar. It's the dehydration that is really dangerous.
Exactly. Now, what about the non-ketotic part? Like in the old name, hyperosmolar, hyperglycemic non-ketotic coma.
Right.
What's the difference when it comes to ketones? How is it different from DKA?
Oh, yeah. That's a really important distinction. So in DKA, you have this huge lack of insulin, right? And that forces your body to break down fat for energy, which creates these ketone bodies. And those are acidic, and that's what causes ketoacidosis.
Okay.
But with HHS, you usually still have a little bit of insulin being made. It's not enough to handle the glucose, but it's often enough to prevent that big fat breakdown and those high ketone levels.
Gotcha.
So you might have some tiny, tiny amounts of ketones, but you don't have the big drop in pH, the acidemia.
Yeah.
The pH usually stays pretty normal, above 7.30.
Okay, so it's non-ketotic. It's not producing those ketones.
Exactly.
Now, you mentioned the brain trying to protect itself. Like, what's going on there with the brain?
Oh, yeah. So the brain, it's pretty amazing, actually. It tries to protect itself from losing too much water.
Right, because of that high serum osmolality. So it makes these things called idiogenic osmoles.
Idiogenic osmoles.
Yeah, big word. But basically, they increase the osmotic pressure inside the brain cells, and that helps them hold on to water.
So the brain's like creating stuff to try to balance it out. Wow, that's incredible.
Yeah, it's wild. But that's why we have to be so careful with treatment. Like, if we drop the blood sugar and that osmolality too fast, the brain might not be able to get rid of those osmoles quickly enough.
Okay.
And then fluid can rush back into the brain cells, and that causes swelling. cerebral edema,
Oh,
which
no.
is really bad news.
That's bad. Okay, so we can't slam the brakes on this.
Exactly. You got to ease into
Got
it.
to be very deliberate. Wow.
Yeah. So the brain being smart, it helps in the short term, but it's something we really got to think about when we're treating HHS. It makes us go slow and steady. Really important point.
Okay. So how does HHS actually present? Like, what are the signs that someone might have this? Well, there can be some overlap with what you might see in DKA, like increased peeing, feeling really thirsty all the time, weakness, fatigue. I mean, all those things are tied to high blood sugar and dehydration. But the patient's history, that's really key.
Right.
We want to know about their insulin, if they've missed any doses, their diet, any other meds they're taking, have they had any recent infections, things like that, cardiovascular events.
So a lot of it's like, detective work, putting the pieces together.
Yeah, exactly. Got to get the full picture.
Now, what about during an exam? Are there any signs that would point more to HHS?
Yeah, the neurological signs are big here. They're a major clue. Because of the decreased blood flow to the brain from dehydration, folks with HHS can have, we call focal neurological deficits.
Mm-hmm.
So weakness on one side of the body, vision problems, delirium, confusion, and even coma in severe cases. And those kinds of things, you don't see them as much with DKA. And then we look for signs of dehydration, like dry skin, dry mucous membranes, although, with obesity, those signs can be harder to spot.
Right.
You might also see rapid heartbeat, a drop in blood pressure when they stand up. We call that orthostatic hypotension, and maybe rapid breathing if there's a bit of acidosis. And sometimes we even see signs of long-term poor blood sugar control, things like acanthosis nigricans. It's these dark patches of skin. Or, oral thrush, recurring skin infections, especially if HHS is like the first sign that someone even has type 2 diabetes.
So it can be the first presentation. Wow. So taking a good history, doing a thorough exam, those are really critical first steps.
Sure.
But how do you know for sure? How do you diagnose HHS?
Well, the diagnostic criteria for HHS, they were established a while back, but they're still the standard today. So the main things we look for are a plasma glucose level over 600 milligrams per deciliter, an effective plasma osmolarity greater than 320 milliosmoles per liter, and then the absence of significant ketoacidosis.
Right.
Which means the blood pH is pretty normal, bicarbonate levels normal.
Okay.
And that old term, hyperosmolar, hyperglycemic, non-ketotic coma, we don't use that as much anymore because not everyone with HHS is in a coma.
Right.
Even if their glucose and osmolarity are really high. So the terminology has evolved a little bit.
Gotcha. So what about lab tests? Like, what are you specifically looking at in the lab?
Okay, so a fingerstick glucose, that usually shows super high levels, like 600 to 1200.
Wow.
We also check the hemoglobin A1C. That gives us an idea of, their average blood sugar control over the past few months.
Right.
And the serum osmolarity, as we talked about, that's going to be way up.
Okay.
And then a comprehensive metabolic panel is essential. We've got to check those electrolytes, especially sodium and potassium. And it's tricky because that sodium level might look falsely low because the high glucose in the blood pulls water out of the cells, which dilutes the sodium concentration.
Interesting.
So we have to use a correction formula to figure out the real sodium level. And potassium, that's a whole other story.
Oh, how so?
It can look normal or even high at first because the lack of insulin pushes potassium out of the cells.
Okay.
But the total amount of potassium in the body is usually low because they're peeing it all out. So we have to be really, really careful when we replace potassium and watch those levels closely, especially since dehydration can mess with kidney function.
Okay. So a lot of moving parts there.
Yeah, lots to keep track of.
What about the acidosis, and the kidney function? What are you looking for there?
Right. So the bicarbonate level is usually near normal in HHS, like above 22 millimoles per liter. And the anion gap, which tells us about the unmeasured acids in the blood, that's usually normal or just slightly elevated. And that's different from DKA. In DKA, the bicarbonate is low and the anion gap is high because of all the ketones.
Right.
If the anion gap is a bit high in HHS, it's usually because of lactic acid buildup from poor blood flow due to the dehydration.
Okay.
So we also check the kidney function, BUN and creatinine. Those are often high because of dehydration.
Makes sense.
And a urine analysis will show high specific gravity. There'll be glucose in the urine, but only minimal or no ketones.
Right.
We do a complete blood count, too, looking for signs of infection, because that's often what triggers HHS. And, the hemoglobin and hematocrit can be high because the blood is concentrated from the dehydration.
Makes sense.
We also use arterial blood gases to check for the level of acidosis, which, like we said, should be mild or absent in HHS. So the pH is generally above 7.3.
Okay, so a lot of different tests, but they paint a pretty clear picture.
Right.
Now, let's talk about the really important part. How do you treat HHS?
Okay, well, managing HHS, it takes a team effort. Often, you've got an endocrinologist and a critical care doc working together.
Right.
And the absolute first thing, we got to make sure their airway's clear, they're breathing okay, circulation is good. The ABCs.
Big ABCs, right.
If they're really out of it, like their Glasgow Coma Scale score is less than 8, we might need to secure their airway so they can breathe properly.
Okay, so making sure those basics are covered, what's next?
Okay, so after that, the next big thing is hydration. We got to hit that dehydration hard with intravenous fluids.
Okay.
We usually start with a bolus, a big dose of fluids pretty quickly to get their blood volume up.
Yeah.
And then we follow that with a continuous infusion at a rate that depends on their age, health, and how dehydrated they are.
Right.
So for adults, that might be like 200 to 250 milliliters per hour. Kids, we usually adjust it based on their weight. And you know what? Just giving them fluids, that actually helps lower their blood glucose. Yeah, it helps by reducing those counter-regulatory hormones we talked about. Electrolyte replacement is huge too, especially potassium. But we got to be super careful with that and keep checking those levels.
Right. Because you said earlier that potassium can be tricky.
It is. It can shift around really fast during treatment. And if we correct it too quickly, it can cause problems, especially if their kidneys aren't working well.
Gotcha. So what about insulin? When does that come into play?
This is where it's different from DKA. With HHS, we often hold off on insulin at first. The focus early on is all about fixing that dehydration, because that alone can often bring the blood glucose down quite a bit. If we start insulin too early and drop the glucose too fast, it can actually increase the risk of cerebral edema, especially in kids.
Right, that brain swelling.
Exactly.
Okay, so slow and steady wins the race here.
Yep. Initial target for blood sugar is usually around 300 milligrams per deciliter.
Okay.
And in kids, we usually rehydrate and fix the electrolytes over a longer time, sometimes up to 48 hours, again, to protect that brain.
That makes sense.
We want to avoid that complication at all costs.
Right. So are there any other conditions that might look like HHS? Things that make it hard to diagnose?
Oh, absolutely. There are a bunch of things we have to think about. Anything that can cause an altered mental status, like hypoglycemia, low blood sugar, or other electrolyte problems, like really low or high sodium. Hyperammonemia, that's high ammonia in the blood, intoxications with certain substances, even uremic encephalopathy, that's in people with really bad kidney failure. And then we have to make sure it's not DKA, although the lab tests we talked about usually help us with that. Diabetes insipidus, that's a condition that messes with your fluid balance. It can cause high sodium and dehydration too. So that's on the list.
Wow, so it really does sound like a lot of detective work.
It is. It takes a good history, careful exam, and the right lab tests to get the diagnosis right.
Okay. So for someone who has HHS, what's the outlook? Like, what can they expect?
Well, the good news is that the prognosis for HHS has gotten a lot better over time, especially with prompt and appropriate treatment.
That's good to hear.
Yeah, but the overall mortality rate, it's still something to be concerned about. And it's often more tied to how severe their other medical problems are. The things that triggered the HHS in the first place, rather than just the HHS itself. Elderly patients who come in with a really deep coma and low blood pressure, those folks tend to have a tougher time.
That makes sense. Now, what about complications? Like, what can happen during treatment?
Well, like we said before, electrolytes can get out of whack, especially potassium.
Right.
Hypokalemia, that's low potassium, and hypoglycemia, low blood sugar. Those can happen because of the fluids and insulin we use to treat HHS.
Right.
So we're constantly monitoring their levels.
That makes sense.
Cerebral edema, that brain swelling, it's rare, but it's really serious, especially in kids.
Right.
And it seems to be linked to dropping that blood glucose and serum osmolality too quickly.
So slow and steady. Again.
Always.
Okay, so looking ahead, how can you prevent HHS from happening again?
Patient education is absolutely key here. People with type 2 diabetes and their families, they got to understand how important it is to take their meds consistently, check their blood sugar regularly, just like their doctor tells them to.
Right.
And really important, stay hydrated, especially if they're not feeling well or if they have an infection.
Okay.
And just being able to recognize those early signs of high blood sugar and knowing when to call the doctor, that can make a huge difference in preventing things from getting worse.
So to sum all this up for you listening, HHS is serious, but it's manageable. It's a complication of type 2 diabetes, and being aware of the risk factors, knowing the difference between HHS and DKA, those are really important.
Absolutely.
And getting medical help quickly, that's essential.
Right. And while all the, the medical details can seem complicated, I think understanding the basics is really what matters. The really high blood sugar, the severe dehydration, and how it's different from DKA. That's crucial for anyone with type 2 diabetes or who cares for someone with it.
Yeah. And if you're listening and you have any concerns, any questions about managing your own diabetes or anything we talked about today, talk to your doctor.
Definitely, they're the best resource.
Yeah.
They can give you advice specific to your situation.
So as we wrap up our deep dive into HHS, here's a final thought. We know there's a strong link between things like diet and obesity and the risk of developing type 2 diabetes and its complications like HHS.
Right.
So what can you do? What proactive steps can you take to be healthier and maybe lower those risks down the road? It's something to really think about. Thanks for joining us for this deep dive.
Thanks for having me.